Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today my topic of discussion is about wet age-related macular degeneration and especially the use of OCT in the diagnosis and the management. The patient who presented to my clinic and he had been suffering from wet ARMD. It was already a cicatrized choroidal neovascular membrane in both eyes. These are the photographs. Here we can see the left and the right slides that there is a grayish-white subretinal membrane which is occupying the central area, the macular area, and they just going temporally also. Along with their in the inferiorly, you can see some pigment changes, pigment clumping over there. So this is a classical photograph of a patient suffering from choroidal neovascular membrane which is cicatrized and suffering from age-related macular degeneration type wet. Right fundus photograph of the same patient. Here again you can see the same changes which are more pronounced in the left photograph. You can see choroidal neovascular membrane in the form of grayish yellow over their membrane, which you see if you focus, they are inferior to the under the blood vessels, so they are subretinal. Another photograph where it is more clearly shown that it is along the blood vessels also, and especially temporal to the macular area in the right eye. These things are happening. This patient presented to me that the vision doctor has decreased further in my right eye, although it is already decreased and counting fingers 4 feet, 5 feet since long time, but it has further decreased. So when I advised OCT macula of this patient, here you can see that in the right OCT there is a subretinal fluid which is shown hyporeflective, subretinal fluid. Along with that, there is intraretinal fluids also. Yes, they have been shown in the right slide where you can see a slope, a plateau, and under it there is, you can see hyporeflective area. These are the areas of the subretinal fluid. And also if you go a little bit on one side laterally, you will see intraretinal fluids. So it means this patient has got now again the activity over there. The choroidal neovascular membrane, which was inactive, have started again shown activity. They are leaking over there, and this thing now needs treatment in the right eye. But if you please consider the right eye, the things are same over there. You can see there is no fluid, no intraretinal, no subretinal fluid, and there are cicatrized blood vessels which can be shown in hyperreflective manner just along the retinal pigment epithelia. Over there you can see in the left eye, which is shown over there. The slides of the patient almost 6 years back, and if you see here the same patient, both eyes were treated with the same disease, and the activity subsided. In the right and the left OCT macula, there is no fluid. There was nothing over there, no intraretinal, no subretinal fluid. So it was stable. The vision, as I mentioned, because of this cicatrization, scar formation, the vision had already decreased, but it was stable at that point. So the patient was okay 5 years back. And the recent advances and recent developments I have showed you in the last slides, that the right eye has shown again the activity, and this patient now needs again the treatment with intravitreal endothelial growth factors in the form of Lucentis, Avastin, or many other things which are available, which we will discuss their roles and their pros and cons. So he needs now again the treatment in the right eye to control this activity. Talk about the wet ARMD. There are multiple causes and risk factors for this disease. It may usually a disease of old people, aged people. Then it has been attributed to the smoking, to the cardiovascular diseases, a deficiency of different micronutrients in the body, family history, hypertension. So all these things have been attributed along with the high cholesterol levels. And even genetic predisposition has also been studied. So multiple factors are working in this disease, which usually affects the aged people. When we talk about this choroidal neovascularization, where these vessels take origin from, this is the question. These vessels basically take origin from the choroid vessels, and they penetrate through the Bruch's membrane, and then these vessels proliferate between Bruch's membrane and retinal pigment epithelium. Yes, and then they can even pass through into the subretinal space. They can even make anastomosis with the retinal blood vessels. All these things can happen over there, and these are not normal vessels. Yes, these vessels have a tendency to bleed. When they bleed, there is hemorrhage, there is cholesterol deposition, lipid deposition over there, and when these vessels shrink over there, arborize or cicatrize, there is scar formation over there, fibrosis element occurring over there. But as all this activity is going on in the macula, which has got the highest concentration of cones, so it compromises the vision. The central vision of the patient is compromised because of all these activities, which are the consequence of the proliferation of these new vessels, which have come in these aged people and affecting their central vision. I mentioned on examination, these patients usually present with decreased vision, severely affected vision. Yes, and if you do examine the anterior segment, it will be perfectly normal, no activity over there. You will not find significant changes except some age-related cataract changes. But when you go in the fundus examination, you will find grayish-green subretinal membrane, which will be inferior to the deep to the retinal blood vessels. You can see hemorrhages, lipid exudates, all these things, and it is old. You can find cicatrization. If you give the patients the Amsler grid chart, the scare pattern chart, they will tell you that they are having problems in it. They will tell you about the scotomas formed over there. They cannot see the lines properly, so their central vision is basically affected in this disease. Talk about the OCT, we can find different types of patterns. As I mentioned, in this particular case, in the right eye, you can see that there is subretinal and intraretinal fluid. This comes to us as hyporeflective in the OCT. But if there is a fibrovascular pigment epithelial detachment, then OCT will show us moderate hyperreflectivity between RPE and Bruch's membrane. Yes, and if there is hemorrhagic pigment epithelial detachment, then there will be hyperreflectivity between RPE and Bruch's membrane with attenuation of deeper structures. So things keep on changing with the different patterns over there. And if sometimes even you can find over there RPE tear or RPE rip with choroidal neovascularization, this RPE tear or rip can be seen over there when retinal pigment epithelium, you will find over there that the margin edge will be curled under the pigment epithelial detachment. Disciform scarring, subretinal, hyperreflective material, and the loss of the ellipsoid zone. Yes, the ellipsoid zone is lost over there, and there is hyperreflective area scarring. So different patterns can be seen over there in different types of stages of the disease. Earlier we used, and still we use, the fundus fluorescein angiography to establish the case, which shows us the classic patterns and the occult patterns. We also used indocyanine green angiography, but as new modalities are coming, so choroidal neovascularization can also be evaluated with OCT angiography. This is a diagram, this is a slide. I have shown you a patient with choroidal neovascularization, where you can see there is a moderate hyperreflectivity in the retina. Along with there, you can see basically it shows us the presence of choroidal neovascularization, which is shown here in the red dots over there. Basically, it shows us has an edge as compared to the OCT, because before the development, it can show us the presence of choroidal neovascularization. Yes, it is has an edge over these, and nowadays very helpful for the diagnosis and the management and further their evaluation. Talk about the treatments. As we discussed about the diabetic retinopathy, here again there are the blood vessels, and vascular endothelial growth factors is the cause, so it has to be countered, and for countering we have the anti-vascular endothelial growth factor. The first medicine which was FDA approved was pegaptinib, that was used for the treatment of this wet AMD to control the choroidal neovascularization, but it has been replaced by ranibizumab, bevacizumab, and after that many medicines came, aflibercept, and now the recent is brolucizumab. So all these medicines have their own pros and cons. This latest medicine, brolucizumab, this is considered that it has a low molecular weight, so in one volume more molecules can be given over there to treat over there. But studies have shown some intraocular inflammation and vasculitis elements. So all these are being used with their own pros and cons, but the basic target is to control the vascular endothelial growth factors. Once they are controlled, these vessels can also be controlled. I mentioned the ranibizumab was the FDA approved medicine which was approved for the use, while bevacizumab is off-label use medication. The study was done to make a comparison with those medicines in controlling the blood vessels in the retina, and it was found, and they concluded that bevacizumab was not inferior to ranibizumab, but the response in bevacizumab was more varied in higher percentages of both gainers and losers, and more frequently observed retinal fluid on SD-OCT at 12 months when compared to the ranibizumab. But these both medicines are being used for the treatment of the retinal neovascularization or CNV. Another study which was conducted to see the efficacy of ranibizumab. It was administered for the intravitreal for 2 years, and they concluded that it prevented vision loss and improved visual acuity with low rates of serious adverse events. Yes, 2 years they did this, and they concluded in patients with classic or occult CNVM secondary to the age-related macular degeneration. The study was conducted to make a comparison between ranibizumab and this is photodynamic therapy, in which we give the patient vertiporfin dye, and then we give the subthreshold levels of the lasers to control the CNVMs. So this anchor studies also showed us, and it concluded in this 2-year study that ranibizumab provided greater clinical benefits than vertiporfin photodynamic therapy in patients with age-related macular degeneration, predominantly classic CNVM. Yes, with new onset, predominantly classic CNVM, rates of serious adverse events were low with ranibizumab. Apart from this, pharmacologic treatments, surgical treatments have been tried with little success. Submacular surgery has been tried, but it can cause cataract and retinal detachment. Macular translocation has been tried. Even pneumatic displacement of the submacular hemorrhage has been tried, but even then you need to control these choroidal neovascularization with anti-vascular endothelial growth factors. So there is not much success with these surgical interventions. As a case I wanted to discuss with my respected audience, that how after a phase of inactivity, even after 3-4 years, these blood vessels, the choroidal neovascularization, can manifest and can cause further decrease in the vision. These patients should be given Amsler grid charts to them, which should they keep at their home, and they should regularly see. And if they find any changes over there, they can contact their physician for further evaluation and management. I want to thank my respected audience for their attendance and attention. I hope this presentation will be beneficial in their clinical practice. Thank you.